Start.
Morning. Today we'll start the series of the first of the series of fetal echo sessions, and today we are going to see on the fetal four-chamber view. Little modification compared to what we do every year, and every year we have been starting with first how to do simple basic steps for fetal echo, but we have decided to go step by step in detail. So today we will see the four-chamber view and see everything about the four-chamber view, the normals and the abnormals. So today is divided into 3 steps. The first we will see is step by step how to get a normal four-chamber view, what all to see in a four-chamber view. Second is that what can we see in a four-chamber view and what can't be diagnosed in a four-chamber view. And the third is that the kind of defects which are seen in four-chamber view, little about all the defects. This is important because initially the concept of fetal echo started with an understanding of doing a basic scan, which included only a four-chamber view. And it is an important step to be followed by all radiologists. However, over time, it was realized that it can pick up only 50-60% of the cardiac defects, and hence the outflow tracts were included over time, which then can pick up to 80-90% of the cardiac defects. So, the normal four-chamber view, how do we get it? And also, ways to make sure that we are covering everything in a four-chamber view. First of all, we will see that we need to decide about the lie of the baby. So as soon as we start doing a fetal echo, know that the lie of the baby, whether it is transverse or not, and also the laterality. Laterality means we need to decide what is right and what is left for the baby. For that, we will have to decide first the right side of the baby, left side of the baby, and then decide what structures are on the right and the left. For a fair understanding of the visceral situs, including the stomach and the liver. And then we come down to the heart, size, axis, and position. Go to the four-chamber view. We see all the components of the four-chamber view in the heart and also the pericardium, the rhythm, and the function. This we will do an anatomic survey, functional assessment, and when we are doing this, we will have some management plans being made. So see first, how do you decide the laterality in this? Now, there are a couple of ways to decide right in a baby. This is one of the 3 ways that we can use the figure which is given here. It means that we need to get an actual section of the thoracic cavity of the baby. Now, how do we do that? First of all, you need to get the baby in a sagittal plane, in the sense that the baby needs to be lying like this, with the head lying on the right side of the screen. But if the head is lying on the left side, you need to use the left-right button inward. So yet again, the baby is lying like this, the head on the right side of the screen, and then rotate 90 degrees clockwise. This will give you a section of the baby's chest. The actual section of the baby's chest, you can sweep from the abdomen a little and come to the thoracic cavity. To go into the thoracic cavity, you will get a cut section like this. It could be in any of the 4 possible positions. So, for example, in this section, this is the spine and this is the sternum. Now, as we have the hung here. Now, how do we decide what is left and what is right? So, we follow this figure. This is spine. So, this corresponds to this. This is spine, this is the sternum, this is left, and this is right. So, if you can see that the left and the right this far, you can see the descending aorta, the heart bubble on the left side, the of the heart on the left side, that's the stomach bubble, the descending aorta, and the heart. So everything is on the left side. You want to decide what is left, what is right, then you can subsequently go further to understand where is the descending aorta, where is the IVC, where is the heart lying, where is the stomach bubble. After deciding the left and the right, we go to the understanding of the visceral situs first. So once you get the axial section, you can go back a little between the abdomen and the chest area, where you will see the aorta to the left, IVC to the right, and the stomach bubble to the left. In this figure, as we understand, this is posterior, this is anterior, which makes this as left and this as right. So you see that the stomach bubble and aorta are on the same side, and IVC is on the opposite side. So this gives understanding about the visceral situs. After we come back to the heart. When we see the heart, we see the lie of the heart in which position inside the thoracic cavity. So whether it is positioned in the left side of the chest, the right, or the center. And once we decide that, we decide about the axis. The axis is measured by drawing lines. The full line is drawn across the enteroposterior of the chest, that is from the sternum to the spine, and the line is drawn across the septate, that is atrial septum and interventricular septum. Angle which is formed between these two lines is called the cardiac axis. The cardiac axis is around 45 degrees plus or minus 20 degrees, which is within 20 degrees would be abnormal in this fact, even if heart is on the left chest, but the axis is extreme leftward, it points towards outflow tract abnormalities, for example, double outlet right ventricle, pathology, etc. Cardiac axis. The cardiac size. Now, the can be measured by measuring the diameter or measuring the circumference or by measuring the area. Usually, it is less than 0.45. On average, most of the measurements range from 0.35 to 0.45. If it's more than 0.45, it is abnormal. If it is less than 0.35, also it is abnormal. Action of the heart is important within the chest. Something else is also important, which is the base x-axis. That the apex axis is towards the left side, it means it's levocardia. Otherwise, it means it's meso or dextrocardia. So you need to make sure that it's levo positioned. It's levocardia. The axis of the heart is around 45 degrees, and the circumference is between 0.35 to 0.45. Basic understanding, go into how to get the four-chamber view. Now, once we had got that based on the laterality, the axial section, the axial section itself will give you a four-chamber view. Now, I decide that I am correctly cutting. I cannot have more than one ribs cut. That means I need to cut the chest in a single plane, which is above the diaphragm. And what is going to give you a four-chamber view. You got this, and then you sweep a little to the chest at the level of diaphragm, you will get a four-chamber view. And you can see this is stomach bubble and this is aorta. You come to the heart and you get the apex of the heart and the base of the heart, and you get a four-chamber view. I am not cutting at more than one rib. And what you will get is a four-chamber view. Now, there are three types of four-chamber views which are described. They meet as apical, basal, or axial four-chamber view. Now, if my apex is pointing like what is there in this view, it's an axial section. That means the apex base axis horizontal like this. The apex is pointing, then it's the apical view, and if my axis is pointing down, it's a basal view. Just all types of four-chamber view. So avoid confusion. It does not matter whether it is apical, basal, or axial. Well, when you're trying to see the interventricular septum, your false defects in the ventricular septum are more when the IVS is particular way. And if you see VSDs, it's always important for you to confirm it in another type of a four-chamber view. What happens here, we can see here, you are at an axial section. The four-chamber view is cutting heart like this. You are in axial section of the chest, just above the diaphragm, and the view is seen this way. If you get the four-chamber view, what is important is that the rib should be there on each side. The crux of the heart should be in the center. That's the correct orthogonal plane. That's the correct way. You can see here, you will see a single rib, and you see the crux of the heart where you have the interatrial septum, the interventricular septum, and the AV valves seen together. The components which we see in a chamber view, most important is that you see the right ventricle and the left ventricle and confirm its morphology, and you see the right ventricle is on the right side to the left ventricle. Ventricle should be reaching the apex. Very, very important understanding. The apex should be formed by the RV and the LV both. This gives you an understanding of the proportion of right and the left ventricles. Normally, the right ventricle is equal to left ventricle or a shade bigger. To what can you expect? Maybe up to 1.2:1 is an acceptable proportion. So here you have almost an axial four-chamber view, and you see the right ventricle and the left ventricle. You see the obturator band. You can also correlate it with the AV valves to make sure that this is right ventricle, this is left ventricle, this is slipper-shaped, this is more trabeculated. This is the interatrial septum. The foramen oval, you see the flap which is there towards the left atrium. Flap of foramen oval is always seen inside the left atrium, which defines the left atrium in fetal life. And the size of foramen oval is important because you can have premature foramen oval closure. And if I pick it up, there are ways to pick it up. In general, the size of the flap should be equal to the aortic valve diameter. Foramen oval defines the left atrium, and it should be enough to take the flow from the right to the left side. Next most important thing is the AV valves should have an offset. So you see two AV valves and you see a difference in position. So you see offset, which is the most important understanding. Subtle AVSDs. When you use the subtle AVSDs means you can have a primer area or inlet VSD, or you would have intact septate but a common AV valve. So what is going to lead to the diagnosis is only the absence of offset, and be an important clue for you to counsel patients to go further for genetic evaluation. Important thing is the pulmonary veins inside the left atrium and the distal aorta which lies behind the left atrium. The left atrium should be like pulled ears. It should not be blunt. Like pulled ears. You can see here the left atrium is like pulled ears. And there's no distance between the descending aorta and the left atrium. That means you do not have a separate confluence lying behind the left atrium, and the pulmonary venous drainage is normal inside the left atrium. The ventricular septum is intact is also an important understanding. A four-chamber view has fallacies. We will in the next slide how you can see false VSDs or VSD you don't see it. So on color Doppler, two things. One is the AV valve regurgitation, and second are the pulmonary veins which are draining into the left atrium, and the pericardium which is normal. And the rhythm is also an important understanding. You can have a subjective understanding in the sense when four-chamber view, you know that this is an acceptable rate, the squeeze is normal, so that means the systolic function is normal. You can do your Dopplers to make sure your diastolic function is okay, and also an M-mode cut to make sure that you have atrioventricular association. You have an understanding about the systolic and the diastolic function, the rate and the rhythm of the heart. You can consider doing a biometry as when you have a doubt. So measure the tricuspid and the mitral annulus as we decided, the tricuspid annulus is equal to the mitral or a shade bigger than the mitral annulus. The AV valve measurement is done in diastole when the valves are open. The ventricles can also be measured. This is done especially when one of the ventricle looks not acceptable in size, and these measurements are also done at the end of diastole, and they are done just at below leaflets. Interventricular septum and the free walls also measured for thickness in situations where it looks like it's not normal, and the transverse dimensions of the atria can also be measured. So this is the role of biometry in a 4-chamber view. You can do this using 2D or M mode. The main 4-chamber view is satisfactorily done. To start with, you make sure that the stomach, the aorta, the heart, and the apex of the heart, everything is lying to the left. The atrium is to the right of left atrium, and right ventricle is to the left of left ventricle. Now, how do you decide what is right and left? I think a lot of significance is related to the foramen oval into the left atrium. The cystic venous drainage and the pulmonary veins could be used along with it. The AV valve should have an offset. Both ventricles should be reaching apex. Both ventricles should appear similar in size, or ventricle may appear a shade larger. And PFO, the foramen oval, should be of the size of the atrium should not appear ball. It should be having pulled ears type of morphology. So to make sure that these things are there, you know that the heart is not much as 4-chamber view is concerned. So what have you ruled out? You have ruled out an atrioventricular septal defect. You have ruled out posterior VSDs. The posterior VSDs include the inlet VSD and the posterior muscular VSDs. You have ruled out tricuspid valve abnormalities, including Epstein's. You have ruled out mitral valve abnormalities and hypoplasia of either of the ventricles, and also a total anomalous pulmonary venous drainage. Lesions which we cannot rule out in a 4-chamber view are the atrial septal defects, the small VSDs, and partial anomalous pulmonary venous drainage. And obviously, the anterior defects, the outflow tracts and the anterior VSDs, we haven't still reached into. Major pitfall in a 4-chamber view is the false defects. So you can see here the ventricular septal defect, which actually is not there, but you can see false dropouts. And there are artifacts which you could see on 2D and also on color Doppler. So whenever you see it in 4-chamber view, you always make sure that you go into outflow tract and double check it, or you change the position of the heart, in the sense that if you get an actual cut compared to an apical or a basal view of 4-chamber, you could make sure that the defect is not there. So always make sure that you see it in other views before understanding that it's a muscular defect. These are very commonly seen in the muscular septum, which are false, and also in the membranous septum. Understanding now what are cardiac defects which we need to pick up in a 4-chamber view. So now you can start from the AV valves. So you could have absence of offset, or you can have individual problems with the AV valves. You can have ventricular septal defects. You can have the proportion which is not normal between the ventricles, and you can have problems with the pulmonary veins. So you can divide these defects into sections. You AV valve related problems where you have an atrioventricular septal defect or double inlet left ventricle, or you can have AV discordance. When you have hypoplastic right side or left side, you can vein problems like PAPVC, ESDs, especially the muscular ventricular septal defect. And in a 4-chamber view, you can also see certain other additional information like arrhythmias, ventricular dysfunction, tumors, and aneurysms. So about each defect now. Ventricular septal defect, as you can see it in this video, is complete absence of offset. Now, log offset, when it's frank, complete, common, ASD is very easy to pick up. So, when it is related to partial defect, it sometimes gets a little tricky. also see that whether you have ventricles which are well balanced. Or make sure that you see ventricles which are well balanced. It's a partial defect like this, what you see it in the second video where there is no VSD. You need to pay a lot of attention to the ducts of the heart. You find one more way of picking this up. When you in a four-chamber view, you feel that the offset is not well visualized. You can actually go to a view where you have cross-section of the AV valves, which is similar to the Sejal cut in subcostals, what we get postnatally. And if the mitral valve is hugging the septum, you're not able to see the cleft so well, but the mitral valve is hugging the septum, it's likely going to be absence of offset. Please make a point that you always check for differential insertion of the tricuspid in the mitral valve. If you have an AV septal defect, also go through the previous records. If you have increased NP or tachycardia, then the possibility of associated AVSD becomes more. Ventricular septal defect is one defect which you can diagnose in first trimester. And whenever you see AVSD, what are the other things to make sure? You see that there is AV regurgitation or not. Are the ventricles balanced? Have any sign of isomerism? The aorta and the IVC lie on the same side of midline. You can consider karyotyping, that you check for rhythm. Complete heart block is in association with AVSD. So you diagnose AVSD, you need to monitor them during pregnancy because AV regurgitation and rhythm, both these things can change during gestation and can lead to heart failure. Understanding at the level of AV valves is a double inlet left ventricle. You can see in this figure, both AV valves are inserting into the level morphological left ventricle. Ventricle is the one which is dominating and ventricle is hypoplastic. Left ventricle is easy to diagnose because you will see one chamber smallish, and then when you focus on the AV valves, you'll realize that both the inlets are going into the same dominant left ventricle. That left ventricle constitutes a significant proportion of single ventricle, univentricular physiology. All the times you have malposition associated with this, you do not see the great arteries in this view. RV hypoplasia is one of the ways to suspect double inlet left ventricle. If you diagnose that, you go further in terms of relationship of great vessels and decide the plan further. Remember that this is a dominant left ventricle morphology, which is one of the best prognosticating factors for a Fontan operation. Now, in this figure, we can see gap of foramen oval. So this is the left atrium. This is the descending aorta. So this is the left atrium. And along the left atrium, what attaches is the tricuspid valve and the right ventricle. The tricuspid valve is inferior to the mitral valve. You can see here the offset. That is left atrium with right ventricle. This is atrioventricular discordance. Now, when you see this atrioventricular discordance, it can be in isolation. In isolation means what? The left ventricle is then connected to aorta and right ventricle to pulmonary artery. So this is called isolated AV discordance. And it's a situation where if you just do an atrial switch, it will be completely normal for the baby. However, of the times, it's not isolated discordance, but it's double discordance. Double means the left ventricle then gives rise to the pulmonary artery and the right ventricle gives rise to aorta, which is double discordance. Now sweep further anteriorly and try to open up the great vessels, the issue, whether it's isolated or double discordance, will get cleared. And further planning will be based on that. You can see the right ventricle actually is attached to the left atrium. The other way to suspect inversion, the atrioventricular discordance is that in this situation, the right ventricle is going to be posterior. So, if you get a sagittal cut of the baby and see, LV will be anterior to the right ventricle. So, that's another clue to suspect that the ventricular looping is not normal. So, the situation where you have L-looped ventricles. Now, when you have that, you need to make sure that you have a ventricular septal defect, whether you have associated tricuspid valve abnormalities in terms of displacement and regurgitation. Do you have pulmonary stenosis, relationship of great vessels, and also rhythm is okay because atrioventricular discordance commonly can be associated with heart blocks. So again, this is a situation where you would monitor them during pregnancy for development of heart blocks, pulmonary stenosis, etc. And if double discordance, your plan would be different. If it's isolated discordance, your plan would be different. One more entity related to valves is tricuspid atresia. Tricuspid atresia is easy to diagnose because you do not see AV valve and the foramen oval is wide open from right to left in a normal direction. You may have a VSD and great arteries could be normally related or malposed when you open up the outflow tract. It may proceed with pulmonary stenosis or pulmonary atresia. The entity which is easy to diagnose is pulmonary atresia, intact ventricular septum. Pulmonary atresia, intact ventricular septum also can have RV which is hypoplastic, and the tricuspid valve could be of varying morphologies. So atresia, intact RV you could pick up because your tricuspid valve and RV may be hypoplastic, and that gives a clue in a four-chamber view. So whenever you see your right ventricle hypoplastic, it's a hypoplastic right ventricle where you may have tricuspid stenosis, tricuspid atresia, pulmonary atresia, intact ventricular septum, etc. The other important entity which you need to diagnose in fetal life is the Epstein's anomaly. Now, Epstein's anomaly, on the right side of the heart, placement compared to the dysplastic tricuspid valve and your tricuspid regurgitation. Important to have an understanding, and this tricuspid regurgitation is one thing which can give rise to hydrops because the ventricles do not like volume in fetal life. The ventricular compliance is poor. You can have significant hydrops as the pregnancy advances. When you diagnose Epstein's anomaly, you can see here in this figure, this is not an Epstein's, but both the AV valves are prolapsing and dysplastic. So the situation where you have dysplastic tricuspid valve with normal attachments and significant AV valve regurgitation. Wherever you have AV valve regurgitation, it's important to follow during pregnancy and make sure that the child does not go into hydrops. Now, when you see an Epstein's, what is important to understand is how much the functional RV cavity is, the size of PO is okay, do you forward flow across the right ventricular outflow tract, etc. So this is the end of all the situations where we have abnormal AV valves. Coming to this, also a very common entity which gets diagnosed in fetal life, where you have the left ventricle which is clearly hypoplastic. This is hypoplastic left heart syndrome. So you have the left ventricle which is so small, it's difficult to miss this during pregnancy. And very subtle clue initially before even it enters into this phase is the direction of PFO. Now, not the PFO shunts from the right to the left, but when the left ventricle is so small, it's shunting bidirectionally or from left atrium to right atrium. So the clue is you see the left ventricle, you see the right ventricle forming the apex, the PFO is left to right, and the mitral valve is atriotic. Hypoplastic left heart, like atrioventricular septal defect, is an entity which can be diagnosed very early. It can be diagnosed in fourth trimester when the NT scan is done, and that gives an opportunity to rule out chromosomal abnormalities. The presence of mitral regurgitation, the size of the ascending aorta and the aortic arch would decide the long-term future, including the flow across the foramen oval. You can have premature foramen oval restriction in fetal life, which can give rise to high pressures in the left atrium and pulmonary vasculopathy. That means that you have the venous congestion developed in fetal life, which is really a bad prognosticating factor. Similarly, now we will include all the left heart lesions. Hypoplastic left heart is frank, very difficult to miss, but at the same time, coarctation of aorta has its own positive and negative roles. Now, how do you diagnose coarctation of aorta? The most common way of suspecting it is the right heart which is more dilated compared to the acceptable limit. So as we understood, the right heart should be a shade bigger than left heart. But what to do if it's more bigger than what we are used to? So here you can see that the proportion is more than 1.2:1. So when it's like that, you try to look for subtle other signs to see if you have coarctation or not. However, in four-chamber view, there are two things which can make you suspect. One, as we said, the right heart more than the left heart, and second is LSVC. There's some correlation which is found between the presence of left superior vena cava and coarctation to suspect coarctation. In this situation, we have to understand that based on this sign, if we suspect, there are lots of chances that it will not be coarct at the end of the day. So probability of CHD is there, but there are false positive and false negatives. False positives means you do not have coarct at the end of it, and false negative means your right heart is not dilated in four-chamber view, and still you have a significant coarct. So now this is one situation where you may be able to provide reassurance, and hence it's important to at birth based on this sign. Critical aortic stenosis, though it's an entity which we diagnose in outflows, you can suspect it in four-chamber view. It is associated with severe LV dysfunction. So here you can see the left ventricle is severely dysfunctional. The left ventricle is severely dysfunctional, and you see these hyperechoic things, which ischemic changes in the mitral valve chordae, sometimes in the left ventricle, which can give you a clue that this child might be having critical aortic stenosis. The other things in four-chamber view which can make you suspect is the direction of PFO. The PFO starts shunting from the left atrium to the right atrium, and that's because of the LV dysfunction and the increased left ventricular and diastolic pressures, sometimes along with mitral regurgitation. See the left ventricle like this, not functioning with EFE, you can suspect critical stenosis. Now about the outflow tracts. Now we come to the third entity, which is the total anomalous pulmonary venous connection. Now as we understood, TAPVC is difficult to diagnose in pregnancy. However, we can suspect it. It's difficult to diagnose, and that's because the is very little. There's only 2% of the total cardiac output which goes into the pulmonary veins, and hence the flow is going to be very little. You can see the left atrium is actually appearing bald, and you see this one extra structure which is present behind the left atrium. So the confluence which is separating the descending aorta and the left atrium. Whenever you do not see those pulled ears in the left atrium appears bald, they suspect TAPVC to see a edge between the descending aorta and the left atrium. Now, supracardiac TAPVC, you might also see a vertical vein with the descending aorta behind the left atrium. So it's called a double vessel sign, and these things can make you suspect the diagnosis of TAPVC. Now, coming to simpler lesions like muscular VSDs, I personally feel muscular VSDs are the most difficult, because for whatever we have seen, they're very easy to diagnose if you get a good four-chamber view. However, muscular VSDs will always be confusing for you. Now here you can see that you see a defect here in the mid-muscular septum, and you see the flow into curve, which is quite satisfactory. These are isolated muscular defects, and muscular defects, the incidence is much higher in fetal life. Lots of these VSDs will close even during gestation. Muscular VSDs do not have any more implications because associated chromosomal anomalies are much less. If VSDs will be a part of atrioventricular septal defects, we have already discussed the interventricular septal defects in AVSD. Now coming down to the last concern which we have in terms of miscellaneous things like rhythm, function, etc. Now, even before you do a Doppler or M mode, if you see this four-chamber view, you can realize that this is a bradycardic heart and this is a tachycardic heart. Tachycardia and tachycardia can subjectively be picked up as soon as you get a four-chamber view. Four-chamber view, you can see this. Once you have this understanding whether it's brady or tachy, then you further can go for your M mode and Dopplers to decide what type of arrhythmia you have, and also Dopplers to understand whether you have any evidence of heart failure. Now here you can see this is a ductus venosus Doppler. Now ductus venosus Doppler normally will not have such significant flow reversal. These are negative waves and these are significant flow reversal. This you can get it in hydrops, but you can also get it in heart box where the atria is pumping, the AV valves are closed. And so do M mode to find your atrioventricular association. This is important, which is easily striking when you do a 4-chamber view with ventricular dysfunction. So here you can see in this that the heart looks a little bigger and also the pumping is not normal. So if you have biventricular dysfunction like this, then you will think in terms of biventricular cardiomyopathy, and then you need to think what is causing it. So the etiology could be genetic, metabolic, infective, or even non-compaction. So in a 4-chamber view, you try to see if the ventricle looks non-compacted. At the end of it, most of the situations where you have biventricular dysfunction, which is not associated with a structural problem, you may end up with no understanding about the etiology in fetal life. And then important is to see progression in utero, because they can develop hydrops. Remember, ventricular dysfunction like AV valve regurgitation may not be well tolerated in fetal life and can cause significant systolic dysfunction. Anemic assessment needs to be done over time during pregnancy till the baby delivers. Cardiac tumors in a 4-chamber view, as you can see here, sometimes it's very clear. You might see tumors which are small, and you might see tumors which are so big. So this is a tumor which is occupying the whole of the left ventricle to that extent that it has created functional mitral stenosis and aortic stenosis. So it's behaving like a hypoplastic heart with hydrops and pericardial effusion. Whenever cardiac tumors are diagnosed, the most one, as you know, is cardiomyomas. And whenever you see a cardiac tumor in a 4-chamber view, it's important to make sure that the rhythm is okay, the outflows and the inflows are not obstructed, and then you follow them up during pregnancy for any deterioration in terms of development of arrhythmias or development of AV valve regurgitation. And after aneurysms, can be seen in 4-chamber view if a complete sweep is done from posterior to anterior at this level. So now here you can see it in this figure. This aneurysm is in the left ventricle and it's seen only when you sweep posteriorly. And you can see that this is an aneurysm which is seen in the right atrium. So whenever you see this dilatation of the right atrium, which is out of proportion to the right ventricular size, you think in of atrial dilatation or aneurysm. This picture can also be seen in localized absence of pericardium, which is not possible for us to diagnose in fetal life. Aneurysms, make sure that you sweep completely. In a 4-chamber view also, your sweep has to be there from posterior to anterior to make sure that your myocardium is normal. Once you diagnose these aneurysms, you need to make sure the rhythm is okay, the child is not in failure, the AV valves are not leaking, and follow up during pregnancy for development of arrhythmias and hydrops. I think we have covered all the defects which we can see in a 4-chamber view. Echogenic focus. You hear both ventricles have this hypererectile structures, and this is bilateral echogenic foci. Echogenic focus is now not anymore in the indications for fetal echo, but practically it still stays an indication, and lots of references still come for a check. What is the significance of echogenic focus? 6% of the normal pregnancies can have echogenic focus. There is a little concern about genetic associations when you have biventricular, but that association is not very strong. So you need to put multiple other things together like maternal age, the rest of the NT scan and anomaly scan and markers in the picture to decide whether it's real indications for fetal echo or not. Understanding, I haven't got a single isolated echogenic focus as an abnormal heart or an abnormal karyotype. So we conclude today's session with an understanding that the fetal 4-chamber examination has to be a part of a second trimester screening. You can use certain things like magnification, color Doppler and cine loop to make your understanding better. Use a checklist which we went through. Understand what limitations you have in terms of evolving diseases. This is important because things can change over time, as we saw. Your valves can start leaking, your ventricle can become smaller as gestation progresses. And always make sure that you go to the next step of vessels. Four-chamber view identifies all complex congenital heart diseases like univentricular hearts. However, for diagnosing overall heart defects, it has a sensitivity of 50% and specificity of 100%. A basic scan can pick up 48% of the heart diseases. Extending the basic scan, which includes the outflows, can pick up 80% of the heart defects. And fetal echo can pick up everything. However, the initials of fetal echo, if we strictly follow, only 20% of CHDs will be picked up because 80% of the heart diseases happen in babies of mothers who do not